Hello, my name is Frank Gillum. I'm professor of neuroscience and neurology at the University of Kentucky, and today we are doing Module 4 of the EpiPort Clinical Research Curriculum on the topic of methods, specifically the selection of outcome measures. Outcome categories or ways to define outcome measures are often divided into two major groups. First is the clinical or medical outcomes, and as most everyone participating in this program understands, that those are some type of physical measurement or a cognitive measurement, typically something like serum concentrations of a drug, spike rates on EEG, seizure rates, reaction time or memory tests from cognitive assessments would be typical clinical or medical outcomes. Now, evolution of another type of outcome has evolved in the past 10 to 20 years, which is focused on what are called patient-reported outcomes, often referred to as PROs. Now, these are measures based on patient experience, and examples would be symptom severity, adverse medication effects, quality of life assessments, mood assessments, etc. The NIH and other research organizations have emphasized that patient-reported outcomes are complementary to clinical or medical outcomes, and many require them in clinical outcome studies, including FDA-monitored drug studies. Our next slide regarding outcome measurement properties focuses on the aspects of evaluation that determine the quality of the measurements. These are typically reliability, validity, and responsiveness. Reliability is the degree to which a score or measure quantifies the accuracy of the assessment, and there should be minimal change upon test-retest. For example, there should be minimal difference in high-quality assessors, and we'll discuss specific elements of reliability in the next couple of slides. Similarly, validity is another aspect of the evaluation of measurement properties, and it's summarized as the degree to which an instrument assesses what it's actually intended to measure. And we'll talk about the major components of validity in just a moment. Responsiveness is the ability to detect change over time. So we obviously want to use an instrument that would be able to identify improvement or worsening of the subject's state. For example, a seizure severity measure should be able to measure the improvement in seizure intensity or severity after an intervention which improved the overall seizures. More specific discussion of reliability, and I've mentioned these just so you have a basic understanding of how to evaluate measures that you might be intending to use in a study that you're developing. Internal consistency, often measured as Cronbach's alpha, is the correlation or intercorrelation of the items within the instrument. This just means that across the group of subjects that are studied, that the items consistently correlate with each other in a specific direction. And I won't go into details of the mathematics of this. You can read more about it if you're interested. But it is just a measure of the internal consistency reliability. Test-retest reliability, as its name indicates, is the ability of the measurement to not change over time or in repeated measures when the subjects have not changed. And pragmatically, this is done by letting the subjects in the validation and reliability testing phase of the instrument development take the instrument, score the instrument, and then in a relatively short period of time that is long enough for the patients or the subjects to not remember how they scored the test, but close enough in time for them to not have a significant change in their status. And that generally is felt to be about 2 weeks. So many test-retest components of the validation and reliability testing will be 2 weeks apart for the test-retest assessments. This is measured by a kappa statistic, so that you see how closely the items correlate between the two measures or two assessments. Generally, we like a kappa coefficient or kappa statistic to be 0.8 or greater, with the range being 0 to 1. Similarly, inter-rater reliability is the ability for equally competent and trained persons assessing, or raters, being able to score similarly when using the instrument or assessing the instrument. And this is would be important for something like a systematic assessment of a psychiatric diagnosis, for example, or a classification of seizures or epilepsy protocol. And similarly, inter-relater reliability uses a kappa statistic, and we'd like for it to be 0.8 or above. 0.5 to or 0.65 to 0.8 is often considered acceptable, but less than 0.5 of the kappa statistic would indicate a poor reliability and probably requires improvement in the measurement. Validity also has several subcategories. Construct validity is the ability of the measurement to assess the specific topics or areas that it intends to assess. This can be done by comparing different groups, for example, fully controlled patients with seizures to patients that are having recurrent seizures, because a seizure severity scale would obviously be more higher score in the patients having continued seizures, or if they had generalized tonic-clonic seizures versus a group that did not have generalized tonic-clonic seizures, the scores of the seizure severity scale should be greater in those having generalized tonic-clonic seizures, and that would be an example of supporting construct validity. Content validity is a more subjective measurement. Often that is determined by groups like target sample groups that would be assessed to give their opinion of the type of items within a measure. That could also be experts within the field judging the content and quality of the items within a measurement. Again, it's a more subjective type of validity, but is generally included in validity assessments. Criterion validity is the comparison of the instrument or items in the instrument to an external standard. That could be termed concurrent validity, which is how does the current instrument compare to another instrument that has previously been validated that measures a similar topic or concept. And to use the seizure severity example again, if we're trying to refine a seizure severity scale and give new dimensions and maybe more specific aspects of seizures as classification systems are changed, for example, you could still use an older seizure severity scale that was previously validated to compare to the new to support concurrent criterion validity. Predictive validity is also in the category of criterion validity, but it's a little bit different. And this would be if you used the seizure severity scale before a new intervention, used a new intervention that had a strong effect on generalized tonic-clonic seizures and improved those in a group, that the seizure severity scale would also improve with retesting after the intervention. And that would be an example of predictive criterion validity. As we think about choosing questions and developing measures or endpoints, I just emphasize a few general ideas. It's advised that the problems are perhaps more powerful if they come from your own experience and your observations from your clinical care and your interactions with patients. It's often advised that you keep a journal out of your experiences with your clinical care to keep you kind of thinking through and mindful of potential evidence gaps and important problems that patients experience. And the examples of these could be specific patient outcomes, self-report problems. They could be inadequacies or problems within the care delivery system that we all confront in our clinics, technological limitations that have changed dramatically in recent decades with advancing imaging technology and digital EEG, but still require improvement. It's obvious that we need to understand the evidence gaps from within the literature, and there are many things that can facilitate us in our enriching our understanding. I always emphasize worth it to just leave PubMed open on your computer. I often in clinic am looking up the evidence within the literature that I'm confronting on an individual patient to see if what's available, and digitization of large literature databases has made major improvement in our ability to do this in recent decades. Other aspects of the literature that are very supportive and helpful to us include the Cochrane collaboration. Many of you are familiar with this. The Cochrane collaboration systematically reviews randomized controlled trials of specific areas within different aspects of medicine. And so within epilepsy, there are multiple systematic reviews from within the Cochrane collaboration. So that's a place to start to look for a systematic review of a topic you're interested in. Also, the Agency for Healthcare Research and Quality is constantly reviewing the literature, taking advice from professional organizations, and updating areas that they consider important evidence gaps. And you can look to see what they emphasize as a guide to potentially fundable questions and types of endpoints that they're interested in utilizing and focusing on. The NINDS, or National Institutes for Neurologic Disorders and Stroke, in 2014 issued a set of benchmarks for research that we'll review in a little more detail in just a moment. But that is a good starting place also to identify areas that the NINDS and the epilepsy research community and leadership within the American Epilepsy Society have emphasized are high priority evidence gaps that we should all be focusing on. The NIH Reporter is a database of all funded NIH grants, and you can search by topic. Again, a very rich resource to guide us in areas that have already been funded and have existing research, but also can give us insight into limitations and evidence gaps that need closure. And you can look at other types of studies similar to something you're interested in and see how other investigators used specific measurements, instruments, or endpoints that can guide you in your research topics also. And we'll review each of these components of the Epilepsy Research Benchmarks and an example from NIH Reporter over the next few slides. The 2014 NINDS benchmarks are listed on this slide. It's not the complete list. The 4 topic areas are complete, but I just selected potentially relevant sub-areas that you can each review. I would encourage you to go back to the original, read through them, because it's very helpful, for example, if you're applying for a grant, to actually cite the benchmark that is related to your study. Because if you're interested in developing an intervention that might improve self-management, for example, you might say refer specifically to benchmark 3F in your early in your application as validation of the importance of the topic that you've selected for your study. Now we'll do an example of searching the NIH Reporter and using a study to work through types of questions that have been asked and instruments that have been utilized, and how results from one study could guide us to topics or specific questions for subsequent studies specifically related to the instruments that we select. I'm using an example of my own because it's easier to be critical of myself, and I think it's just a topic that I understand well enough to present in some detail. So I just put my name in and searched NIH Reporter and found studies that had previously been funded. You can also, in the second section in the text search, type in epilepsy or seizure severity or neonatal seizures, some specific topic, and find studies that are specific to that area. So you can search it and get a lot of information related to what has been funded and specifics of the studies by the text search. So up comes a study of mine published that was funded a few years ago on intractable epilepsy, pre-surgical strategy and outcome. You can see that it started in 1995, and you can look at different aspects, including the results, the description. The abstracts are always published, so you can get considerable details about the study. This is a paper that published out of the first collection of the completion of the data set from that study. And you can see that the profile of mood states, the PALMS summary score, interestingly was the most strongest correlation, or had the strongest correlation with each of the 3 main areas of quality of life: mental health, physical health, and role function. And I provide this example to you because when I was developing the study, I was looking at cognitive outcomes, clinically relevant outcomes like whether patients were driving, whether they got off medications or not, and we included a cognitive battery of memory and executive function. One of my mentors at the time, Barbara Vickery, reviewed the study and each of the outcome measures that I was utilizing, and she came back to me and said, well, if you're going to be measuring patient-reported outcomes, especially quality of life, you need to include a mood measure, and hopefully that included anxiety and depression, because those are often predictors of aspects of patient report. So I included the profile of mood states at the recommendation of Kim Metter, one of my senior colleagues at the time. And lo and behold, that becomes the strongest predictor of many aspects of outcome from this study of temporal lobectomy for refractory temporal lobe epilepsy. And that led me to focusing on depression as a important component of epilepsy, and we developed a randomized trial that, again, I, in a search in NIH Reporter, found and present to you as the example of the abstract on treatment of depression, comparing sertraline to cognitive behavior therapy, looking at multiple outcomes, including seizure frequency, adherence to medications, mood, and quality of life. Again, just an example of how you can use NIH Reporter, and also an example of ways you can learn about endpoints and the way other investigators have utilized and developed measures for studies that have previously been funded. I think it's valuable to look again at the resources that the NIH and other organizations in collaboration with the American Epilepsy Society provide that really support our ability to do quality clinical research. I refer you to the Clinical Research Toolkit, which is here on this slide, but is you can basically Google it and find it quite readily. But it includes many previously developed mechanisms to help us do clinical research. And if you look at this list that they provide, things like clinical trials checklist, developing a budget, how to approach monitoring of the trial, developing a protocol which integrates the endpoints and is really based on the endpoints and measurements that you've chosen for your study. So it's really a very useful tool. I would also focus on one of the items in the list, which is the NINDS Common Data Elements. And the Common Data Elements were developed by a panel or a committee of clinical researchers who did reviews of the literature and identified the prior instruments that had adequate reliability and validity to support their use in clinical studies. And this is a quite extensive list, and you should probably take an hour or two when you have time to look through the NINDS Common Data Elements websites because they have a very comprehensive set of instruments that are previously developed and validated to assist us. And you can see that they range, these previously developed instruments range from seizure diaries to quality of life assessments to the bottom left column, which is neuropsychological test results. And this is not the complete list. It's a much more extensive list in the website. The right column is the comorbidities focusing on depression and anxiety. So you can select from these lists instruments that already have demonstrated reliability and validity. But also I emphasize that as you apply for funding at the NINDS, they actually require you to use common data elements when available. So it's critically important for us to be aware of these. The leadership for the development of this educational module emphasized that we shouldn't limit, though, our research to those instruments that are already included in the common data elements, because it may be that there's a topic of interest that does not have a previously validated instrument, and you may want to develop one yourself. So they encourage me to emphasize we should all be open, that we may need to develop new instruments and do reliability and validity testing that would then allow the new instrument to be included in the common data elements and be utilized in our research. And that might serve as the initial phase of a larger project that you would initiate. When we think about choosing questions and developing endpoints, I just reiterate that it's important that it's something that's meaningful to you. It's an evidence gap or a problem that you see in your patients that you really sense as a recurring common limitation. I think that allows you to kind of stay focused and persevere through the process of doing the clinical research, which is often not easy itself, going through the regulatory and administrative hurdles that we all go through in developing IRB approval, et cetera, and getting external funding. It's also important to consider the existing FOAs or funding opportunity announcements, which are published and updated regularly by the NINDS and other funding agencies, program announcements, benchmarks, as we've already discussed, because the better we understand those, the more we can tailor our interest in specific clinical research questions to previously emphasized funding areas and merge them to increase the possibility of our successful funding. Specific aims need to address hypotheses that are testable and quantifiable by reliable and valid assessments, as we've pretty thoroughly discussed. The specific aims need to be clearly worded for the reviewer, and the well-defined outcome measures need to be specified as clearly as possible, and whenever available, utilize the CDEs as we just discussed. In summary, let me reiterate that we really want our research to focus on current limitations, both from within our experience in the clinics and evidence gaps in the literature. The more we can enrich our understanding of current limitations, the better our research questions and subsequent studies will be. We need to develop aims to address specific hypotheses and really focus on a study question. We need to choose quantifiable endpoints or measurements that use reliable and valid instruments. We need to be very familiar with resources already available to us, such as the NIH Toolkit and the Common Data Elements. We should be open to consider developing a new instrument if needed to assess novel outcomes. And we need to use preliminary data or previously published data, point estimates and standard deviations of specific instruments that are related to our research topic that allow us to develop our proposal, such as sample size calculations and other elements. So it's hard to separate choosing instruments from the larger development of the study. They're intimately integrated. And I wish you the very best as you apply these concepts to choosing your endpoints and measurements for your future research.